Good afternoon, everyone, and thank you all for taking time to join the fourth event in the Medical Research and COVID-19 series, sponsored by the Coalition for Health Funding and the Ad Hoc Group for Medical Research. I'm Erin Morton, Interim Executive Director of the Coalition for Health Funding. Before we begin, I want to go over just a couple of housekeeping items. We're using Zoom's webinar format, so all audience members are muted throughout the discussion. We will be taking questions at the end, however. To ask a question, please use the Q&A function to type your question. You can start submitting questions now and throughout the briefing. When you submit your question, please be sure to include your name and the full name of your organization or congressional office. I'd also like to note that this briefing is not open to members of the press, so if you've joined us inadvertently, we appreciate your interest, but would kindly ask that you disconnect at this time. As you know, NIH-supported medical research across the country is a key tool in battling COVID-19 and its wide-ranging impact. Our organizations partnered on this series to give both advocates and congressional staff an opportunity to hear from the directors of NIH Institutes and Centers about how research to date and ongoing work can inform our response to the pandemic, as well as the impact COVID-19 is having on existing research across the agency's broad portfolio. We have two moderators for today's briefing. Libby O'Hare, who represents the Association of Independent Research Institutes and is a member of the Ad Hoc Group for Medical Research's Steering Committee, will facilitate the Q&A portion of our discussion. And to introduce our speaker for today's briefing, I will turn things over to Mila Becker, Chief Policy Officer at the Endocrine Society and CHF board member. Mila, over to you.
Thank you. CHF and the Ad Hoc Group are pleased, and I'm very honored, to welcome Dr. Griffin Rodgers, Director of the National Institute of Diabetes, Digestive, and Kidney Diseases, to our fourth event in this series. As the Director of NIDDK, Dr. Rodgers provides scientific leadership and manages a staff of over 600 employees and a budget of approximately $2.3 billion. Dr. Rodgers received his undergraduate, graduate, and medical degrees from Brown University in Providence, Rhode Island. He performed his residency and chief residency in internal medicine at Barnes Hospital and the John Cochrane VA, respectively, at Washington University in St. Louis. His fellowship training in hematology was in a joint program of the NIH with George Washington University. In addition to his medical and research training, he earned an MBA with a focus on the business of medicine and science from Johns Hopkins University in 2005 and a master's in legal studies in 2017. As a research investigator, Dr. Rodgers is widely recognized for his contributions to the development of the first effective and FDA-approved therapy for sickle cell anemia. In addition, he and his collaborators have reported on a modified blood stem cell transplant regimen that is highly effective in reversing sickle cell disease in adults and is associated with relatively low toxicity. He has been honored for his research with numerous awards, including the Richard and Hinda Rosenthal Foundation Award, the Arthur S. Fleming Award, the Legacy of Leadership Award, a mastership from the American College of Physicians, the Herbert C. Nickens Award, and a fellowship in the Royal College of Physicians. With that, I will turn it over to you, Dr. Rodgers, to give an overview of NIDDK's current activities. When you are finished with your presentation, Libby will open it up to our audience for questions. Thanks.
Well, thank you so much, Mila, for that very kind introduction. And I want to thank you for visiting us today. It's a pleasure to be here today and to talk to you about how NIDDK is responding to COVID-19 and its impact on our research and on people with the diseases within our mission. I first want to thank the Congress for their strong support of the NIH and biomedical research, and the Ad Hoc Group for Medical Research and the Coalition for Health Funding for organizing today's briefing on this important topic. Next slide, please. As the name suggests, NIDDK's research mission is broad. We support and conduct research to combat diabetes and other endocrine and metabolic diseases, liver and other digestive diseases, nutritional disorders, obesity, kidney, urologic, and hematologic diseases. Next, please. These encompass some of the most chronic, common, consequential, and costly diseases and conditions affecting people in this country. Next slide, please. As this slide depicts, just 3 of the most burdensome chronic diseases affecting Americans today: obesity, type 2 diabetes, and chronic kidney diseases. At NIDDK, we integrate our support of research of these conditions because they are connected, and people are not likely to develop just one of these health problems. As you can see in the gray boxes, a staggering number of people are affected by these diseases, and complications from these health conditions can lead to a lifetime of untold pain and suffering. And all of these conditions are associated with the U.S. health disparities. For example, as you can see in the light blue boxes, obesity disproportionately affects non-Hispanic Blacks and Hispanics. Type 2 diabetes rates are higher in American Indians, Alaska Natives, non-Hispanic Blacks, and Hispanics compared to whites. And also compared to whites, rates of end-stage kidney disease are 3 times higher in non-Hispanic Blacks and 1.3 times higher in Hispanics. These disparities are further exacerbated by the ongoing novel coronavirus pandemic, with increased rates of infections and disproportionately poor outcomes for COVID-19 seen in individuals with these conditions. Next slide, please. Not only does COVID-19 affect vulnerable populations served by NIDDK research, it really touches everything that NIDDK supports, as shown on this slide. Research progress, programs, clinical trials that are underway pre-COVID have had to stop or delay for safety reasons, in turn stalling or delaying new discoveries. The cadre of scientists we support faces great uncertainty and challenges in making progress in their fields and their careers, especially young investigators just starting out, women investigators or others who are disproportionately affected by caregiving roles during the pandemic, and members of underrepresented groups who we've been hoping to attract to the research workforce long before the pandemic. We're also seeing research costs increase. The burden of restarting clinical trials, animal colonies, and other programs and resources is made even more challenging by the need for additional funds and strategies to conduct research safely in the face of COVID-19. Personal protective equipment, extra cleaning, and time sharing in laboratory are just a few examples. And ultimately, there are likely many lost opportunities to pursue new research questions. Next slide, please. All this leads to a simply put yet challenging goal. While addressing the immediate challenges of COVID-19, we also need to keep our eye on that wrecking ball of diseases in NIDDK's mission. Many of these diseases are risk factors for and are possible long-term complications of COVID-19, and we need to pursue research to better understand the connection between COVID-19 and these diseases. In addition, we must continue critical COVID-independent studies to serve all our stakeholders, as diseases in the NIDDK's mission will remain with us after the acute challenge of COVID-19 has passed. We must also continue to integrate the role of social determinants of health and health disparities as drivers in all of these activities. Next slide, please. Thus far, the NIDDK has engaged in a multifaceted response to grapple with the impacts of COVID-19, as shown on this slide. We have done much of this with the guidance of our external stakeholders, including leading scientists and patient advocates who are members of our NIDDK's Advisory Council, and we are continuing to listen to our many stakeholders during these challenging times. First of all, we're supporting research on COVID-19 research as it relates to NIDDK's mission. For example, we funded competitive revisions to ongoing research projects to enable study of COVID-19's impact on kidney, diabetes, and digestive diseases. We're also soliciting new projects to study the impact of the novel coronavirus and COVID-19 disease on organs and diseases of interest in NIDDK so that we might have a better understanding of acute risk, outcomes, long-term effects on people who contract COVID-19. We've participated in efforts with our sister institutes and centers at NIH. For example, we're helping support the National COVID Cohort Cooperative, or NC3 as it's called. This is a national clinical data resource led by the National Centers for Advancing Translational Sciences. And we've also have NIDDK scientists conducting COVID-19 research in our intramural program. For example, early in the pandemic, NIDDK scientists published fundamental studies on how we expel potentially virus-carrying droplets while we speak. These studies are a key part of the evidence base for wearing masks to help prevent the spread of COVID-19. Furthermore, to help relieve the burden on the biomedical research workforce, we support around the country, we're implementing NIH policies that ease concern about awards, spending, and time lost to the pandemic. We're also developing strategies on our own. And another important effort is building long-term trusts that will be critical for vaccine implementation once they become available. These will be especially true for populations disproportionately affected by both COVID-19 and those individuals with conditions that increase the risk of poorer outcomes for COVID-19. And one way we've already begun this is by enhancing some of our community engagement in our clinical studies. As I noted earlier, we're also seeking to increase diversity in our research workforce. And by doing so, we hope to increase talent and to expand perspectives that could advance human health and also strengthen ties to many of the communities we serve, potentially encouraging individuals from these groups to participate in research. We've also built a webpage on our NIDDK website that helps point out various stakeholders to COVID-19 related information and resources. And I've provided the link here at the bottom of the screen. And then finally, we're doing all this while we're keeping our eye on the ball of the NIDDK's mission, seeking a balance between the need and challenges brought about by the pandemic and our goal to continue research that could lead to prevention, treatment, and possibly cures for many of the diseases and conditions within our purview. Thank you once again for giving me this opportunity to say a few words, and I'll be happy to answer any questions that you might have. Thank you.
Great, thank you, Dr. Rodgers, for that informative presentation. So we'll turn now to Q&A, and as a reminder, participants can submit their questions at any time using the Q&A function in the window. And we ask that if you do have any questions that you're submitting, please also include your name and your office or your organization. So let's take a look at some of the questions. So let's start with this one. And you were alluding to this, Dr. Rodgers, I think in your last slide. So Congress has not specifically appropriated any COVID-19 related emergency funds to NIDDK. Has the Institute been forced to use its existing budget to address COVID, or perhaps to forgo potential research opportunities? And if NIDDK were to receive additional funding, what research would be prioritized to answer critical questions?
Sure. Well, thank you, Libby, for that question. Obviously, we haven't received additional funds, so this means that we have to make difficult choices. And we're concerned that there will be insufficient study of chronic diseases that I've mentioned, at least in the near term. The funds that we lost to the impact of pandemic in fiscal year 2020 alone are alarming. And of course, we're anticipating that future costs for restoring the research enterprise will necessarily have an impact on what studies we'll be able to support and at what level. This will likely lead to an overall research slowdown. And given these difficult choices and limited funds, we're also likely to be missing out on opportunities in the COVID-19 space relevant to our research, our mission diseases. And as I noted earlier, we've received input on many of these issues from our National Advisory Council members, and and others. And we're continuing to listen to those on the ground, both to identify the challenges and to get ideas about possible solutions. So thanks again for that question.
Good. And let me ask, we have some questions coming in, which is great. Let me ask one more COVID-related question. So as I'm sure you know, as a result of the pandemic, many labs across the country have been forced to shut down to promote social distancing or to comply with other types of guidance and local regulations. And many are just now in the process of reopening and resuming research operations. So in some cases, you know, researchers will need to restart projects that were halted midstream, and the effects really are diverse. And in other cases, projects may be lost completely. What will be the short and long-term implications for non-COVID NIDDK funded researchers and the research workforce if additional support is not available to help mitigate some of these impacts?
Well, I think the long-term outcome could be quite ominous. Obviously, we're going to have to sort of balance how much we put into COVID-related research, given the fact that a lot of this research is, a lot of the diseases are within our mission, and we really do have to understand why these groups are differentially impacted. What is it about them that leads to them developing the disease more readily, having poorer outcomes, and whether in fact the disease itself may foster and accelerate the progression of these particular diseases. So we need to have a certain funding base just to answer those fundamental questions. But we also have to continue our research in the many areas that I showed on one of those earlier slides. Now, of course, you know, as you alluded to, many of these institutions have been shut down, and the things that are disproportionately affected, I have to say, are some of our clinical studies and clinical trials. And this cuts across the spectrum. And so it's been difficult to continue these trials. It's been difficult to recruit the individuals, new individuals into the trials. And these are the things that, you know, will really either postpone, delay, or potentially, you know, completely abolish our possibility of understanding, you know, the outcomes of those trials. Mm-hmm. Basic scientists with mouse colonies, that may be lost research completely unless we're able to bring that up, and people doing translational research. So it really cuts across the spectrum, and I think that it's important to indicate that even across, as we look at this whole spectrum, there are going to be people who are disproportionately affected. And I really worry about the young investigator pool, particularly women who have child caring and, you know, and other care provisions, because they're not going to be able, in the current circumstance, to provide, to even when their institutions get, you know, opened again, to get the fundamental, foundational research accomplished so that they can move forward and put in applications for Kale Career Awards, their first R01s. And so, you know, we have to keep that in mind as well. So depending upon the types of funding that we're able to get, we're going to have to sort of think about equally all of these different areas where we need to emphasize, and that balance will be somewhat challenging. So again, thanks for asking that question.
Well, and thank you for that response, because I do appreciate that you and others at NIH are really capturing the heterogeneity of the effects, excuse me, of the pandemic is having, both in terms of science as well as an individual members of the research workforce. So appreciate that. So we have a question now from Mary Lee Watts with the American Society for Microbiology. And she thanks you and NIDDK for taking a strong leadership role on the NIH Human Microbiome Project. And the Society has made microbiome research an advocacy priority. What is NIDDK currently doing in this area of microbiome? And how are you coordinating with other ICs? What does the future hold for this exciting area of research?
Well, thank you for that question. And as you know, we along with several other institutes were involved in this work, very early on. In fact, we were one of the lead institutes responsible for the Human Microbiome Project, which was funded by the Common Fund, but it was led by four separate institutes. The vast majority of the research that we are conducting and still conduct are individually based upon investigator-initiated research. In fact, about 66% of the research in the microbiome comes in that sphere. It's not top-down research. These are very good ideas that come from our investigators, and we continue to make great strides and inroads in that area. We're also continuing to fund research that's related to larger questions. One good example of that in the microbiome space relates to understanding the environmental determinants of diabetes of the young. A part of our type 1 diabetes efforts, trying to better understand what are the triggers in people who are genetically susceptible to developing type 1 diabetes that triggers their abnormal immune response. And in individuals who are highly genetically susceptible, from the time of birth to the age of 15, we're collecting a variety of samples: blood, and saliva, and stool, and hair clippings, and nail clippings. But the microbiome aspect of this is truly the most fascinating. Thus far, we've collected about 5 million samples. And what we've already learned from this is that during early childhood development, infant development, the microbiome, in terms of its compositions and constituents, goes through 3 separate phases. And we think likely that this is more generalizable, but the important aspect of this is that we've learned is that mothers who breastfeed their kids, even if it's supplemented with formula, tend to have a more heterogeneous and more mature microbiome composition compared to those who do not. And we're also learning a little bit about the role of small single carbon amino acids or butyric acids and others in terms of the development of the immune system. I know I'm answering a long question, but we really do have a lot in this space. You might also appreciate that just recently, earlier this summer, we came out with a national effort for a strategic plan in nutrition research. And a major component of that now is to better understand what eating plans are more personalized for a given individual. And a key component of that not only is the person's genetics, but the microbiome composition within an individual. If you want to get more information about that, you can visit the NIH's website and type in a nutrition strategic plan, but it'll tell you a lot about how we're planning to study this to ultimately develop a nutrition plan for precision health, which will take the individual in regard. So microbiome is on our radar screen, and it's something that we're really actively engaged in research on.
Yeah, thank you. I think the microbiome issues and then the promise of precision nutrition is a really exciting new avenue for the Institute and for NIH more generally. So let me, we have another question now. This one is from Debbie Forrest with Act for NIH. This is back to COVID. What long-term effects of COVID do you anticipate seeing on liver function, the digestive system, or other areas of NIDDK focus?
Yeah, well, that's something that we're hearing some anecdotal stories from our investigators, and that's why it's good that we do have some some ongoing networks to begin to answer these questions more comprehensively. In fact, we had a call out both for supplements as well as some early funding that we did to try to make sure that as this pandemic was hitting the major metropolitan cities where we have these networks established, that we be able to collect baseline data to then follow these patients in a prospective manner. We're hearing potentially, as you know, that the virus appears to be shed in the GI tract. Whether those particles are still infectious or not is still open to question. But we wonder what the effects might be on the normal absorption process, or the absorption process in individuals who have normal GI function, as well as those who suffer from luminal diseases, like, for example, inflammatory bowel disease, Crohn's and ulcerative colitis, or a more common condition, celiac disease, which affects about 1% of the US population, or individuals with more functional GI disorders or motility disorders. This is something that, again, we're actively looking at based upon some supplements that we have provided to some of our investigators, and hopefully with additional funding, we can expand these quite greatly. You mentioned liver disease, and certainly now that we have hepatitis C is a condition that now is potentially curable with the various antiviral therapies that are out there. And parenthetically was the area that was noted by the Nobel Committee in giving the prize in medicine and physiology this year for the foundational work in hepatitis C. Other liver diseases are becoming more challenging and leading to cirrhosis and end-stage liver disease, including non-alcoholic steatohepatitis. What we don't know is if in individuals who inherit or who get infected with COVID, there is some acceleration of this disease process, because as I mentioned earlier, obesity, which is also a risk factor for NASH, appears to be a risk factor for COVID infection. So that's something that we're going to be actively looking at. In fact, NASH now is likely to be the leading cause of liver failure requiring liver transplantation. So that's, again, an active area of investigative inquiry.
Great, thank you. So as you alluded to in your presentation, NIDDK is tackling health disparities and health equity issues on a number of fronts. Could you expand on NIDDK's efforts to address the social determinants of health as it relates to diseases within your portfolio? And how are you and NIDDK working across the NIH, perhaps with other ICs, to tackle social determinants of health issues?
Sure. Thank you for that question. Well, COVID has really been a stress test, if you would, for health disparities in chronic diseases, underscoring in an unprecedented way there are already devastating impact. Combine, that with the heart-wrenching events of 2020 that have shown, how much work still needs to be done to address racial injustice in this country, which influences many social determinants of health. We really have much to do to stem the tides of illness and death from COVID-19. Again, these disproportionately affected communities, and to prepare to safeguard their health in the future. Regarding what we've been doing, my colleague, Dr. Gary Gibbons, and I wrote an editorial in JAMA that appeared last month, in response to some alarming numbers that were being reported through NHANES that the CDC funds. And it showed, for example, that obesity numbers continue to rise, particularly in these underrepresented groups, and particularly troubling in youth and adolescents in this country. Really unchanged at all over time. What was a little bit more unexpected was that in a lot of work that's funded by the Heart, Lung, and Blood Institute, that hypertension, well-controlled hypertension, while showing an improvement now within the last observation period, is beginning to rise as well. And so uncontrolled hypertension, obesity, and I'm sure, they will also show that diabetes. So these numbers continue to rise. They're rising in these underrepresented groups. And I think our institute and other institutes, NHLBI, NCI, others, have really determined that in order to address these particular questions in a more fundamental way, it may really take more than just sort of a one-off behavioral intervention. It might require interventions actually including other agencies that might begin to address these fundamental social determinants. An example of that, we may want to, and we're beginning discussions in this regard, work with our colleagues in housing and urban development to determine whether changing in housing for certain groups might affect not just one, but multiple of these underlying health conditions, whether it may have a positive effects. Working jointly with the education department, working with our colleagues in Medicare and CMS, Medicare and Medicaid recipients. These may have a greater impact in addition to the fundamental interventions, but it would be interesting to learn. So that's one of the things that we're currently planning in this space in 2021 and beyond.
Great, thank you. And this next question comes from Richard Terman from Act for NIH, and it's a similar flavor on the topic of health disparities and social determinants of health. So he asks, as you noted in your presentation, the diseases that NIDDK addresses afflict some disadvantaged populations in the US far more than others, and we see the same pattern with COVID-19. Has NIDDK been able to fund any COVID-related projects that try to address health disparities that COVID has shown affect Hispanic individuals and Black populations?
Yes, Richard, thank you for that question. And I mentioned that early on, that what we were able to do with existing funds or began to, through funding, through supplements, as well as some initial funding requests, some of those studies addressing the so-called intersectionality between underrepresented populations on the one hand and their diseases, as well as this COVID-19 predilection. The ultimate goal is obviously to address these two at a time to understand what's the underlying mechanism involved in this predilection in people that have chronic diseases. On the one hand, what's the underlying mechanism regarding its high predilection in people from underrepresented groups? There are obvious things that we're already aware of. People from these underrepresented groups, because they're facing the public in terms of their occupations, being more likely to be in the service industry or in the transportation industry, like metro bus drivers or healthcare workers or people who are transportation drivers, are more likely to come in contact with the general public, oftentimes living in multi-generational housing facilities. And so the possibility of socially distancing is, it's much more difficult. But I think we all understand that. The other questions are there other determinants that have, yet to be explored. And so those studies, based upon those some of the supplemental funds and funding with some existing resources, or begin to not fully address the question, but be more hypothesis generating as we see it, setting the stage for perhaps larger investigations into this area of research.
Great, thank you. So another question on perhaps a little bit of a related area, although not necessarily COVID specific. So we're increasingly seeing the critical role that health-related social and behavioral sciences research plays in advancing the mission of the NIH. Can you discuss NIDDK's portfolio of social behavioral sciences research and what you see as some of the research priorities in that space?
Mm-hmm. Well, of course, we've been engaged in this for quite some time, particularly in our areas of obesity as well as in diabetes research. Perhaps sort of the best example of this are some of the social and behavioral studies that we've done to both identify people who are at high risk of developing type 2 diabetes and developing intensive lifestyle interventions to prevent them from developing it, the so-called diabetes prevention program. So that really showed, some both remarkable and some unexpected findings that this lifestyle intervention, for example, was highly effective, 58% reduction in development of diabetes, ultimately in high-risk groups who already had prediabetes. But I guess what was most unexpected is that people who were 60 or older at the time that they were randomized in this study actually had the best effect. We were told going into this, you'll never get people in their 60s to begin exercising in a manner that, is called for in this protocol, 30 minutes a day, 5 days a week. And not only were they able to do it and sustain it, but that intervention actually led to a long-term beneficial effect. The study is now sort of in its 15th year, and some of the findings are still quite durable in this population. But compared to the 58% overall decrease in developing diabetes, individuals who are 60 or older at the time of randomization had a 71% reduction. And so it's never too late to start. And this is information that we need to give our family members. We also have social and behavioral interventions in the form of some of our trials in obesity research, for particularly in pregnant moms, because we realize that moms who are overweight and who may have gestational diabetes during that pregnancy not only are at greater risk of continuing to have obesity, but that becomes imprinted upon the infant born during that period of gestation, putting that child at risk for obesity and diabetes in later generation. And even that might explain why we're seeing type 2 diabetes at younger and younger ages. And so interventions at one stage might have, generational beneficial effects. Of course, social and behavioral research is also sort of part of what we're doing in chronic kidney disease to slow the progression of the disease, to make sure that if we have technologies that, might be beneficial, it doesn't work if people don't use it. And so we're recruiting psychologists and behavioral therapists into a number of these trials to develop some innovative ideas in this space. And so it really is a parcel of a lot of the work that we're currently engaged in.
Great, thank you. So I think we have time maybe for one or two more questions. Let me ask this one first. So the federal government is currently operating on a continuing resolution until December 11th, and it's likely there'll be another stopgap funding bill after that. How does the lack of a final appropriations bill impact NIDDK's operations and the grants that you all have out in the field? And what priorities will not be accomplished if NIDDK does not receive additional federal fund or increased federal funding in the next year.
Sure. Oh, thank you. Well, you know, having long-term, well-established funding, you know, really makes it better, obviously, for planning purposes. It's very difficult. While, of course, let me first state that we appreciate the funding that we have received, it's very difficult to think long-term about funding in certain areas in particular without the prospects of knowing that that funding will continue as opposed to starts and stops. The area of clinical studies and clinical research is a very good example of this. For clinical research, you first have to recruit patients, then you have to enter them into trials, and then you have to sort of complete the trials and write up the results. And at least in my view, it's somewhat unethical to be engaged in a trial when you're not sure, you know, that you're able to actually fully fund it to get it completed. And so that's an area that we may have to sort of delay the beginning of these trials until we are sure or relatively sure that we have funding, you know, well established. Even in some of the basic research that we're doing, what really leapfrogs and get these studies really moving on a very nice path is the need for newer technologies and the adoption of those technologies and the acquiring these new novel techniques really requires an infusion of for one-time cost, and of course that might mean that in the absence of a well-established base, we may have to turn to continuing ongoing research that we know what the yearly totals of those might be. So it not only affects clinical research, but it also affects some of our innovative basic research efforts as well.
Great. Well, thank you so much, Dr. Rodgers. I see Erin has rejoined us, so I think we're getting near the end of our time. We really appreciate your thoughtful responses to all of these questions. And thank you again, and I'll turn it back over to Erin.
Thank you.
Thanks, Libby, and I'll echo your thanks to Dr. Rodgers for joining us today. And on behalf of the Coalition for Health Funding and the Ad Hoc Group for Medical Research, we want to thank all of our participants for joining us today. This concludes our webinar.
Thank you.
Thank you so much.